Next presentation's on antimicrobial stewardship considerations for this area, and it's going to be given by Associate Professor David Andresen. He's an infectious diseases physician and clinical microbiologist with a particular interest in evidence-based antibacterial therapy. He has roles in antimicrobial stewardship, infection control and OPAT services at St Vincent's public and private hospitals, and so he got to park in his own car park today, maybe. Lucky him. So it's great to have David on board. I've met him at a couple of conferences and he always asks really insightful, difficult questions. So after his talk, it's my turn to return serve.
Thanks very much. Actually, I rode my bicycle in the rain. So yes, I do get the feeling that I'm the token local here. So welcome to sunny Sydney and welcome to St Vincent's Hospital. And I was amused to see that my talk goes till 10:40, but morning tea starts at 10:30. So I promise for the last 10 minutes I'll talk really, really loud so you can hear me from the foyer. So why am I here? I guess I'm here because I do both hospital in the home. I think I stole this logo from Barwon Health, by the way. And I do hospital in the home and I do antibiotic stewardship. I'm an infectious disease physician and a microbiologist, though in interest of full disclosure, because Tony Lai might be here, I'm not a paediatrician, and so I'm specifically, in the interest of time, going to not mention paediatrics. That's not because it's not important, that's not because there's no literature there. There's actually a really nice body of evidence around paediatric OPAT, but just because it's not my thing. Okay, so now you're very privileged or perhaps horrified to see something that only my therapist has seen up till now, which is what's inside my head. So this is what I start thinking when I get a call about a potential OPAT patient. Okay, who's the host and what's their disease? Based on their disease, or perhaps based on microbiology, but not always, I think, well, what are the bugs and what are the likely or known susceptibilities? There's actually often a question of, do they need antibiotics at all? There are quite a few infectious conditions that are fundamentally self-limiting and may not need antibiotics. If we do need to use antibiotics, which agents? Are they oral or IV? What are the likely tolerability issues? And tolerability and adherence obviously come hand in hand. What's the collateral damage? That's to the individual patient, but also perhaps you can take a more broad focus and think about community or institutional collateral damage. I must say, as a little aside, that I'm not sure that the resistance issues in a non-hospital-based patient are as potent as they are in a hospital, which is clearly an inpatient setting is a breeding ground for resistant bugs which can transmit from patient to patient. Perhaps those issues aren't quite as potent in the ambulatory setting. Duration, and something that James said, which I completely forgot about, is obviously monitoring and follow-up and ensuring good long-term outcomes and making sure we detect relapse early, which I think has fallen down to about the pituitary gland there. Again, as a little aside, I think probably we all have perhaps subliminal philosophical stances about how the OPAT team sits with respect to the referring team. And obviously this is a continuum, but I came up with two terms that I think are useful here. Are you just a babysitter? Are you just providing an administration service on behalf of a referring team? Or are you usurpers who are actually stealing the patients and you've got to look after them yourselves? But of course, with great power comes great responsibility. If you steal that patient for yourself, you become responsible for their long-term outcomes and follow-ups, which I actually do, but it makes my outpatient clinic really, really busy. And of course, probably the ideal is a mixed model somewhere in the middle of that spectrum, but I'm personally a usurper. So it's terribly embarrassing to find that I'm giving a talk with Mark Gilchrist before me and Mark Gilchrist after me about a topic where Mark has written the best and most thoughtful paper. So it puts me in an awkward position. But Mark talks about the stewardship OPAT dilemma. Now, stewardship people are interested in the most effective, safe and narrow spectrum agent with the least capacity for collateral effects, which is going to make the patient better, okay? The OPAT people, fundamentally, yes, they care about similar things, but there is this one point of difference perhaps where convenience of dosing may take precedence over an agent spectrum of activity. Now, in our hospital, that's code for ceftriaxone. Okay, but in other hospitals that may be code for daptomycin, ertapenem, or a new long-acting glycopeptide when they finally come to Australia. So yes, there are these points of tension. To be honest, we use very little ceftriaxone in our service, so obviously I've usurped things effectively. And this is a nice table in Mark's paper, which is proposed OPAT antimicrobial stewardship checklists. And he's clearly got a much more organised mind than me. And you should all pull out this paper and you should all just read it. But there are a few things that I wanted to emphasise here. Clearly, tolerability, effectiveness, opportunities for IV to oral switch, some governance issues that really, the protocols should be endorsed by drug and therapeutic or antimicrobial stewardship committees, that there should be a two-way street, that the OPAT service should be represented on the antibiotic stewardship community, and if the service is not ID run, that there's a link infection specialist. So all really good stuff. North Americans have come up with a bundle, which I suppose you could think of as a checklist for OPAT as well. And they mentioned one other thing, which is a particular bugbear of mine, ID consultation prior to intravenous access. There is absolutely nothing worse than getting up to the ward for a newly referred patient and who can clearly go home on oral antibiotics and go, oh, and we've just put the pick in. Oh, okay, pull it out. And that's a recipe for a dissatisfied patient, let me tell you. So yeah, so ID consultation prior to definitive venous access, because this patient may not actually need prolonged intravenous therapy. But yeah, the monitoring issues are really critical, and I think we as ID physicians are good at that stuff. And the liaison and follow-up as well. Now, I have to say that some people probably think of ID and stewardship as synonymous. I don't actually think they are. There's people in my department, in my ID department, who I can't get to do stewardship. They've got no interest, they've got no skills, it's just not their thing. And of course, we all know that some ID physicians are perhaps the worst, broad-spectrum antibiotic abusers, and take the point that, well, if I've been asked in, it's time to use meropenem. So don't necessarily assume that all ID people are stewardship people. And clearly, not all stewardship people are ID people. Anyway. So we've heard that there are two nice guidelines. I've not seen the new BSAC guidelines, so I'm going to talk about the slightly older one. But first to North America. So the quite new IDSA guideline does talk a little bit about stewardship. And of course, as all North American guidelines, it's prefaced by a rather tedious literature review. And I will cut to the chase. Basically, they say there are 3 cohort studies of comparing outcomes which have ID review prior, which I'm taking as a sort of a surrogate for stewardship oversight. 2 of them showed nothing, but the best methodologically study and the biggest study did show a lower likelihood of being readmitted during your OPAT journey. They also say that curtailment of unnecessary OPAT has been demonstrated in several studies, with a switch from IV to oral in somewhere between 16 and 39%, and antibiotic therapy at all, that's even oral therapy, was not necessary, in somewhere between 1 and 10%. And other interventions include change in dose, duration, choice, and clearly ID involvement can improve coordination of care. So I suppose it depends on your perspective whether curtailment of OPAT use is a good thing or not. And perhaps in the North American setting, where a lot of these are for-profit privately run infusion centres, there may actually be a perverse incentive to give OPAT to people who maybe could do well on orals, or to prolong the duration unnecessarily. So I don't know that we can necessarily extrapolate the North American data holus bolus to our setting, where we don't hopefully have those perverse financial incentives. But keep that in mind when you're reading the North American literature. So what happens to these patients who are denied OPAT? Well, they generally do very well. And most studies have shown 0 readmissions in denied patients, or relatively few treatment failures. Here's one patient which had 7 treatment failures in patients denied OPAT. 6 of 7 were non-compliant, and the 7th had an incurable infection. So these are patients who, I guess you can argue, should you take on anyway? This issue of non-compliance or non-adherence is a really interesting one. I've just come off a week of clinical service, and I've been called from emergency saying, you need to admit this patient because they will not take their oral antibiotics if we send them home. And I thought that was an interesting philosophical question for me. Is it my view, is it my role to waste or utilise a hospital bed on someone because they are not going to take their tablets if we send them home? And interested to discuss that afterwards. I don't actually know the right answer. So this is the bottom line IDSA recommendation. All patients should have ID expert review prior to initiation of OPAT, and their rationale for that is that there's evidence showing misuse of OPAT, that this misuse can be controlled to some degree by ID expert review, and that when you say no to OPAT, the patients seem to do fine anyway. And this warrants a strong recommendation that ID expert review be obtained prior to OPAT. Well, fair enough. This paper actually didn't get reviewed in the IDSA literature review, and I'm not quite sure why. This was a sort of a theoretical or notional review. They looked at patients who had OPAT, and would they, had they been asked, have changed anything? In 60% of times, they would have changed something, including 30% IV to oral, change your drug in 22%, and about 11% who wouldn't have had antibiotics at all. So that's congruent with their literature review that I've already shown you. And a very recent paper that didn't get into the IDSA guideline literature review, really, because it came out afterwards, was showing that people with IDSA, with ID-led OPAT, were about half as likely to be readmitted to present to emergency, and about 2/3 as likely to return to hospital over 30 days. But this is again in this setting where you've got these privately run for-profit infusion centres. So the British guideline, Jumping Continents, is structured around 5 main topics, and 4 of those topics have some mention of stewardship in it, and I've just summarised it here. The team should include an infection specialist. They don't necessarily need to run the show, but they need to be there and they need to be available, and that person should be in charge of inclusion and exclusion criteria, that the treatment plan is the responsibility of that person in discussion with the referring clinician. So this comes up to this babysitters versus, do we take over care altogether? That it should be subject to local stewardship processes, and that the plan should be reviewed and monitoring should be appropriate in consultation conjunction with the referring specialist. So all fairly unobjectionable statements. So yeah, again, are we usurpers or are we babysitters? So now, given that everyone's talking OVIVA this morning, I thought we should actually look at some of the data which I think I agree, are going to be practice changing and are probably going to challenge us a little bit in terms of our understanding of what value we as OPAT or as HITH people really provide. And that value we provide may not be all about injecting drugs into people. So I'm going to want to talk about cellulitis, I want to talk about endocarditis, and I want to talk about bone and joint infection. So first of all, I wanted to celebrate an Australian paper which I think has gone under the radar a little bit, and that's about cellulitis. And it's a randomised non-inferiority trial. And non-inferiority trials are really, really hard to do. They've got horrendous statistical power issues, and these people did it really, really well on a group of patients referred for OPAT, which was traditionally 2 gram BD of cefazolin for uncomplicated cellulitis. Their primary outcome was how many days till the cellulitic area stopped advancing, and secondary outcomes, failure of treatment, pain, complications, and satisfaction with care. Now, is days to non-advancement the right outcome for a cellulitis trial? I'd argue that it's as good as anything. You could argue days till afebrile, days till CRP reduction, but anyway, look, you can argue about that. The intervention group got Keflex, a gram QID, which was then, in the patients who got cefazolin up front, was then their backup, their oral step-down option. And they all got treated for about 10 days. And fundamentally, it did meet non-inferiority criteria. In fact, there was a trend to superiority, and there was fewer failures of treatment in the oral than in the intravenous arm. So, should we even accept cellulitis onto our programs? I think we should, but I think maybe our value in that setting is more the engagement and the daily review and the close monitoring than the fact that we're shooting up a drug into someone's line. Endocarditis is the next one I wanted to talk about. This is probably a little bit further from prime time than bone and joint in terms of early oral therapy, but I did want to review the data because I think they're fascinating. So as you know, traditionally the endocarditis, we've said, absorption of orally administered antimicrobial agents may be unreliable, and this is generally not recommended as sole therapy for infectious endocarditis, though there have been exceptions, and the most obvious is the injecting drug user population with staph right heart endocarditis, where there's some pretty good data for oral therapy in this group. But you kind of get the feeling that this is just regarded as the least worst option in a difficult population. So can you extrapolate this to left heart endocarditis? Can you extrapolate this to a more adherent, cooperative population? That's always been in question. There are two large-ish, or medium-sized case series from Denmark and France which suggest that you can get good outcomes with switch to oral therapy at about 2 to 3 weeks. And if you think of a patient's journey with endocarditis, it usually takes a couple of weeks to clear the bloodstream, get the echo, make sure the heart surgeons don't want to fix their valve up front, get the lines in and things. But at about 2 weeks, we start getting a bit bored with them in the hospital. And that's when we think, okay, well, should we send them home with OPAT? So this is the Danish case series. These are patients with generally left heart endocarditis. Quite a lot have had surgery during their inpatient stay. This is really not complete oral substitution. These are patients who've had at least 2 to 3 weeks, often more of IV, but then they finish it. Once they're ready for home, they go home on orals rather than going home on another few weeks of OPAT. And they seem to do fine. This is the French study. More than half had surgery, 3/4 had left-sided disease. But again, they're at least 3 weeks. Most of them had about 3 weeks of IV, and when they went home, they had about 3 weeks of oral. And again, they did fine. I haven't put up the whole list. So then the Danes who presented that case series said, okay, well, it's time to do a randomized controlled trial. And so this is the paper which came out in the same edition of the New England Journal of Medicine as the Oviva study on bone and joint. So, non-inferiority, multi-center study, 400 adults in stable condition with left heart endocarditis who didn't immediately need surgery. The primary outcome is a composite of bad things: dying, rushing back for a heart valve replacement, having an embolism, or relapsing with the same bug in your blood. And non-inferiority criteria were met, and in fact there was a non-significant trend to superiority of early oral therapy. What does stable condition mean? This is in the fine print. C-reactive protein dropped to less than 25% of peak value, or less than 20 milligrams per litre, and white blood count is low, and they didn't have abscess formation, and they were going to be cooperative, and they were looking fine on the ward, I think is kind of the bottom line. And here's the outcomes. As you can see, patients with oral therapy were less likely to have these bad outcomes than patients on fully intravenous therapy. And if you look at the components of the bad outcome, there was no difference in surgery, embolism, or relapse, and there was a non-significant trend to less mortality with earlier oral therapy. But it's not super early oral therapy. They tended to go home at about 14 days. They had to have had at least 10 days of IV therapy. But as that fits in with generally the discharge duration in patients with simple endocarditis, I guess we'll probably be seeing fewer patients over time referred. Oops, what have I done? With endocarditis. And if in no subgroup did there appear to be an advantage to complete IV over oral step down. They did use some quirky doses. I must say 1.2 grams per day of rifampicin is quite a lot, and clindamycin 600 milligrams 3 times a day. I can imagine there could be some tolerability issues. They had a few PK data which were more or less reassuring. So you probably can cure well-selected patients with endocarditis after a couple of weeks of IV therapy by switching them to oral. These weird Danish two-drug combinations were surprisingly well tolerated. And again, what do you do with the patient where you just don't think they're going to take their tablets? This is the OVIVA study. So this is a big English study of 30 hospitals across the UK, all bone and joint infections which would traditionally be treated with 6 weeks of IV therapy. So it's a real mixed bag of infections. And they went pretty early. They went to oral therapy at the end, about the end of the first week of IV therapy, and the outcome, which was bad, was definitive treatment failure. So about 1,000 patients. If they were bacteremic, clearly they weren't suitable, and there was a modified intention to treat population of over 1,000 and a per protocol of about 900. So this is what they had. So osteomyelitis debridement, osteomyelitis not debrided, DARE procedure, removal of implant, one-stage revision. So good mixed bag of typical orthopedic infections, and absolutely no difference in the bad outcome of treatment failure. And nor did, when you nutted down into subgroup analysis, was there any particular bug which seemed to do badly with early oral step-down, nor any particular clinical syndrome which seemed to do badly with early oral step-down. And it didn't really seem to matter which oral agents were chosen either. And there was a non-significant trend to better outcomes if rifampicin was part of your oral regimen, which probably has some biological plausibility. Of the 500 people in the IV arm, 50 got line complications, that's about 10%, and there was some pharmacoeconomic outcomes, but they were in a currency that I don't understand, so I won't labour that. So, AMS folk, I think, have a lot to offer in the OPAT space. We'd probably mostly rather be usurpers than babysitters. If you believe the North American data, and I think that this is more or less plausible, about 10% of patients who are referred to you may not need antibiotics at all, and another about 30% should probably be on orals rather than intravenous therapy. That's not to say you shouldn't be involved. You could still provide oversight, but they probably don't need a drip in their arm. If you've got a good multidisciplinary AMS team with ID, micro and pharmacy, we can efficiently provide both clinical and AMS oversight to IV antibiotic patients on your programs. And I think these evolving oral efficacy data, which I've quickly outlined, have the potential to significantly alter the OPAT case mix in the near future. And I think that perhaps means that we should expect that more of our referrals are going to be for patients who need different types of support. They need monitoring, they need encouragement, and they're perhaps going to be harder things to sell to administrators. Administrators get it. Okay, well, you're getting a patient out of hospital with a drip who would otherwise be stuck in hospital on a drip. But if you say, okay, well, this is a patient who we're really worried about adherence, who we think might go AWOL, who's got poor social supports, who's a bit chaotic, and we need to see them every day to make sure that they don't fall off the wagon, that's harder to sell to your budget holders. So I think we probably have some work to do to justify our role in that space. Anyway, I thank you for listening to my talk, and I'd be happy to take questions.